I'm really interested in the physical health outcomes of people with severe mental illness, and I'll show you some of the work I've been doing and some of the things I'm interested in terms of how we can identify and hopefully then prevent some of the consequences of cardiometabolic consequences of severe mental illness. I don't have any disclosures. So I'll talk a bit about the cardiometabolic comorbidity of SMI or psychotic disorders specifically, and really why the status quo isn't working. I'll talk about prognosis research in general as a tool that is routinely used up and down, well, all around the world as a tool for prevention. And then I'll talk a bit about my work on PsyMetRiC. So why am I interested in this topic? So people with severe mental illness die on average 20 years sooner than the rest of the population. The most important contributor to early mortality in this group are preventable physical health causes like diabetes, obesity, cardiovascular disease. This slide really just encapsulates how complicated this picture is. There's an awful lot of factors that are involved in this early mortality. But regardless of the reason, there's really good evidence that from the first episode of psychosis, so psychosis usually precipitates late teens, early 20s, these are young adults, cardiometabolic dysfunction, things like insulin resistance, impaired glucose tolerance, dyslipidemia are already detectable. And that's before we prescribe things like antipsychotic medications, which can worsen that picture. Essentially, the biochemistry of these patients you would expect to see in someone from the general population who is at least 20 years older than them. As well as a moral reason to try and improve this picture, there's quite a strong economic argument to do so as well, because it's a super expensive problem. So over half the total NHS spend on psychotic disorders is swallowed up by treating physical morbidity. And if we could improve this picture, essentially we would save the NHS and wider society an awful lot of money. When people are diagnosed with a severe mental illness, it's common that at some point these individuals will be diagnosed with a physical health condition. Some work I contributed to using whole population data from the Czech Republic showed that after diagnosis of a severe mental illness, diagnoses of nearly every physical health condition that one might imagine we see that they are more lethal in people with severe mental illness. So essentially they're diagnosed more often and they lead to an earlier death in people with a severe mental illness compared with those that don't have a mental illness. Improving physical health outcomes for this group is high on the agenda, not only for patients. So James Lind Alliance is a priority setting partnership of patients and other stakeholders. They report 2 of their top 10 priorities for research relate to physical health outcomes in schizophrenia. More recently, there was a lived experience research agenda for addressing the early death in people with severe mental illness, focuses on better data-driven methods at preventing physical morbidity. NHS England have recently published their Core 20+5 approach. So these are 5 key health inequalities that the NHS England wants to target. And one of those is physical health outcomes in people with severe mental illness. I think the time has come, and I think things like this MRC hub, which is fantastic, that to see something like this funded, the time has come for us to realise that mental illness does not begin and end above the neck. Severe mental illnesses are whole system disorders, and they affect the whole body. A really interesting paper published a couple of years back in JAMA Psychiatry looked at whole bodily systems, brain and body, and looked at how well they might predict severe mental illness. And what they concluded is essentially that the manifestations of mental illness are more pronounced in the body than those that we can identify in the brain. And if we want to predict mental illness, it's better to look in the body than at least what we can currently identify in the brain. I'm going to talk a little bit about insulin. I really like insulin. This is a really oversimplified slide, but essentially type 2 diabetes could be really oversimplified as to be related to having too much insulin. Type 1 diabetes is essentially having no insulin. They both lead to glucose being unable to enter the cells because insulin is critical for glucose to enter the cells, for the cells to function properly. I'll come back to that in a minute. Insulin functions, we have a growing understanding of the importance of insulin function in the brain. Insulin receptors are just distributed all around the brain, particularly in regions that are associated with severe mental illness. And there's a growing appreciation of the complex interplay between glucose-insulin homeostasis in the brain and psychiatric consequences. Some work I did during my PhD, we tracked insulin levels from mid-childhood into adulthood in a relatively large birth cohort in England called Ausbach. Insulin levels were measured in about 7,000 or 8,000 children starting at age 9, then at age 15, 18 and 24. And we did some growth mixture modeling, which is a statistical technique to group similar individuals together in their trajectories of change in markers. And we looked at insulin levels and we looked at BMI. I won't talk much about what we found with BMI, although it's interesting in its links with depression. But what we found with insulin is that essentially raised insulin levels from the earliest point of measurement, so age 9 onwards, persistently raised insulin across childhood, adolescence into adulthood was strongly associated with all psychosis spectrum outcomes in adulthood. Essentially, this study that points to the fact that it's possible that alterations in cardiometabolic dysfunction may be detectable long before psychosis onset, challenging the notion that the physical health consequences of severe mental illness start at the point that the mental illness is diagnosed. They may start long before. So too much insulin relates to higher risk of psychosis. What about not enough insulin? So this is a paper I'm particularly proud of, actually. It was my first senior author paper. And we used, we triangulated methods. We used sort of comprehensive epidemiological analysis in observational data from the whole of the Czech Republic, whole population data, with genome-wide Mendelian randomization, which is a genetic epidemiological technique. And we tracked all of the children over the last 30 years that had been diagnosed with type 1 diabetes, and we looked at their mental health outcomes in adulthood. And we found that, probably interesting enough in itself, that type 1 diabetes increases the risk of nearly every mental disorder under the sun. Except for one group, psychotic disorders, we see a lower risk of psychotic disorders like schizophrenia in children who are diagnosed with type 1 diabetes. Actually, that matches up with what we found in the genetic epidemiological analysis as well. The triangulated methods essentially showed the same result, that that type 1 diabetes may be causally linked with a lower risk of psychotic disorders. MR is like nature's randomized controlled trial. If you've not used it before, it's a great method when used carefully. So in a RCT, it's the best way that we can try and show causality. What we do is and the key step is the randomization step. So what we want to do is take a big and representative enough people, split them randomly in half. And if we do that, the balance of confounders, both the ones that we know about and the ones that we don't, should be evenly split between those two groups. So any difference in outcomes must be related to the only thing that is different between those groups, i.e. that one of them has had a treatment or an exposure. MR is the same. So in our genes are and our alleles are randomly segregated at conception. If we know that some specific genetic variants are highly related to a modifiable exposure, for example, then we can randomly separate whole populations into who has that genetic variant versus who doesn't. The balance of confounders between those two groups for everything else should be evenly split. And so any difference in outcomes must be related to that genetic variant. That's the premise of MR. We looked at whether inflammation, insulin resistance, may be causally related to schizophrenia on the basis that inflammation may increase insulin resistance and may also increase your risk of schizophrenia. So what we did is we looked at genetic variants that had pleiotropy, either they were similarly associated with both inflammation, a measure of inflammation and of a cardiometabolic trait, and then we performed Mendelian randomization to look at associations with schizophrenia. What we found is that a strong evidence for an association of raised fasting insulin, raised triglycerides, and low HDL with schizophrenia. So that triad is commonly referred to as the insulin resistance phenotype. So inflammation-related insulin resistance may be causally related to schizophrenia. We then, in a sort of a multivariable MR step, a bit like adjusting for confounders in an observational study, we essentially adjusted for CRP. So, and when we did that, the effect completely disappeared, showing that stronger evidence really that it's inflammation that might be driving this picture. There's some really cool work going on in Birmingham. I'm brand new to Birmingham, and I'm really delighted to be in Birmingham. So we have a postdoc with us, Connor, whose PhD focused on. He comes from an exercise background and a lab a basic research background, and he looked at in his PhD at whether moderate to vigorous exercise may be associated with reduced inflammation, but also improved psychiatric symptoms. Really interesting work that is ongoing in Birmingham. So just taking a step back and going back to where I started, the cardiometabolic morbidity of severe mental illness. So this is the picture that we want to stop. So first episode, psychosis, that's where these individuals will be being picked up in clinical practice. Cardiometabolic dysfunction, early signs of it are already detectable. Can we do things that prevent this from leading to a preventable early death in this group? Can we prevent the preventable? If we want to talk about prevention, we have to start with Geoffrey Rose. So Geoffrey Rose was an epidemiologist whose seminal work on prevention and the prevention paradox has really transformed what we understand about how to prevent disease. So Geoffrey Rose's prevention paradox, I just have to start with this because everything I say it needs to be taken with this in mind. So everything I'm going to talk about next relates to the high risk or risk reduction approach at prevention of disease, i.e. we take the smaller amount of people right at the extremes of risk and we intervene on those individuals. That is not the best way to prevent disease. The best way to prevent disease are population level approaches to shift the whole distribution of risk to the left. The problem with population level approaches is that they're really difficult and often beyond what we can do in healthcare. These are things like minimum unit pricing or banning junk food advertising, these sorts of like societal level interventions that really require a lot of policy and political buy-in. They're really difficult to achieve, but they are the best way to prevent disease. Going back to the high-risk approach, I'll just focus on Q-risk for a moment. So if you've not heard of Q-risk, but you're over the age of 25 and have been to your GP in the last 10 years, Q-risk probably will have been done on you, whether you know about it or not. So Q-risk is embedded into the GP systems all across the UK and actually in many other parts of the world as well. So Q-risk is a web-based calculator or a risk prediction model that takes into account a number of different items, so predictors, that are routinely measured in health record data. And from that, they plug those into an equation and get you your 10-year risk of having a heart attack or a stroke. Tools like that are really well embedded in clinical practice and into NICE guidelines. So NICE guidelines say that if we have a Q-risk 3 score of 10 or more %, we should be being prescribed a statin and have a really comprehensive cardiovascular assessment. If we score less than 10%, we essentially don't get that much, but we should be rechecked again in a year's time. That's what the NICE guidelines say. The problem is tools like Q-risk and other ones like it are not suitable for young people with severe mental illness. So I did a systematic review of all of the cardiometabolic prediction algorithms that exist. There are loads of them, way more than I thought when I started this systematic review, and it was a real pain to do this systematic review. Most of them aren't worth the paper they're printed on. They've gone no further as a result. Some of them are good, and some of them are being used in clinical practice. But the key thing is that all of them were developed on samples of middle to older age adults. And that makes sense in the general population because age is by far and away the most important cardiovascular risk factor. So you can see on the figure on the right that even if you have no other risk factors whatsoever, just as you get older, your cardiovascular risk increases. So it makes sense in the general population to focus on middle to older age adults because that's where the risk is starting to accumulate. But the side effect of that is that these models are so heavily weighted on age. So I don't think that picture is a very good one. You probably can't see these are the predictors on the bottom that go into a Primrose actually. So Primrose is a SMI specific risk prediction tool. And there are a whole range of different risk factors that go into the Primrose tool. But you can see there that the relative importance that's attributed to age in terms of the weighting that's given to age so strongly outweighs everything else. So essentially you could have every other risk factor under the sun, but if you're young, you'll never score highly enough to warrant any sort of intervention. And that plays out. So I will try not to show you many statistics today, but there are two plots that I'm going to show you that I'm going to teach you how to read. So if you've not seen a plot like this before, it's a calibration plot. So it sort of tracks the accuracy of a prediction model. I'll teach you how to read it. So along the x-axis, along the bottom, is the predicted risk score. So this is the score that the risk tool will spit out. So 0.2 is 20%, 0.4 is 40% risk. Along the y-axis, going upwards, is the observed risk or the observed probability of developing the outcome in the sample that you're testing on. So what we want to see is that those two numbers agree with each other. So the predicted risk is the same as the observed risk. So if we trace that, so we can go from 0.2 in the predicted risk, we want to see the actual risk is 0.2. Vice versa, predicted risk is 0.4. We want to see the actual risk is 0.4. So an accurate algorithm would trace that diagonal line up the middle. What we see when we test these tools in early psychosis, in young people with early psychosis, is a calibration line that's almost on a different planet. There's massive underprediction of risk. So just as an example, let's read up. So predicted risk of 0.2, the observed risk is closer to 0.8. So these tools are just not fit for purpose in our populations of patients. So that led me to develop PsyMetRiC. So PsyMetRiC is a relatively simple prediction model, and that was by design. We did, and that's I'll come back to that in a moment. The first version of PsyMetRiC predicts up to 6-year risk of metabolic syndrome after a first episode of psychosis. The key thing that's different about PsyMetRiC compared with the general population-based tools is that we use data from young people with first episode psychosis to develop the tool. So the tool is tailored and accurate for this group in particular. It uses just routinely collected information, and we had a lot of stakeholder involvement and have an ongoing and lasting collaboration with the McPinn Foundation to ensure what we do is likely to be acceptable to patients as well as being clinically useful. We're on track for regulatory approval in the next 6 months in the UK. That probably is a talk in itself, but the problem is people's eyes glaze over when I talk about regulation. So I'm not going to say any more about that now, but very happy to answer any questions on it if anyone is interested. There's another calibration plot though. So you can see that that's in our external validation. So you can see much better agreement between the observed and predicted risk scores, i.e. we have a much more accurate algorithm when the algorithm is trained and tailored for this population of interest. One good thing that one good thing about keeping PsyMetRiC simple is that it's been more easy to validate in other settings. And PsyMetRiC is relatively well traveled now. We're up to like 9 independent external validations, and there are several others in the pipeline. And that's been a really interesting and really enjoyable process. So generally what we found is that accuracy has retained throughout wherever we've tested. And I think that again is one of the benefits of keeping the model simple. So essentially we've probably sacrificed a little bit of accuracy at the start, but the tool is far more generalizable when we want to test it elsewhere. And that's been a nice thing to observe. One thing we have noticed is that calibration tends to disintegrate a little bit as the crow flies the further we get from the UK. It's been quite interesting. So the worst calibration that we found was in Australia. Probably it's the furthest away that we've tested, even though that you would think that the Australian population is very similar to the UK population. But actually, I think there are differences. But with some fine tuning adjustments, so logistic calibration it's called, essentially very fine tuning adjustments, we can make very population specific versions of PsyMetRiC, and that's what we have now. One of the great things about working with new people in new settings is that people come with new ideas for how we might test PsyMetRiC, and it's been really enjoyable to do this work. So different people have brought different ideas depending on the data that they've got. So for example, we've looked at how accurate PsyMetRiC is in unmedicated versus medicated patients at baseline. We didn't find a significant difference in that. In Finland, we've been able to compare PsyMetRic's performance to FINDRISC, which is the Finnish cardiometabolic prediction model. That was good. We've also tested in individuals at risk of developing psychosis, so young people in clinical high risk or with psychotic experiences in Ausbach, so at risk of developing psychosis. And we've also shown that PsyMetRiC is flexible. So ethnicity is a predictor that's in PsyMetRiC, but the ethnic makeup of the UK, it can't really be equated to other parts of the world. So essentially what we've done in some settings is essentially remove PsyMetRiC and sort of replace it with the ethnic makeup of the local population. And when we do that, so there's an example of the calibration that's on the left at the bottom. That's an example of the calibration in Australia, because we didn't include ethnicity there. And then when we've recalibrated it with the local ethnic makeup, you see that the accuracy improves, so which also shows the relevance of including ethnicity in a model like this. The vision for PsyMetRiC is this. So a young person will unfortunately experience their first episode of psychosis. Usually they'll be offered treatment within a psychosis early intervention service or other community mental health service. At that point, PsyMetRiC score would be calculated. PsyMetRiC is never designed to replace the sorts of universal level interventions that we should be offering to all of our patients. For patient smokes, we should be offering them advice to stop smoke and support to stop smoking. Shouldn't rely on a risk score for that. But there will be, there are, and will increasingly be some treatments or interventions that we don't want to or can't offer to all of our patients. So just one example, GLP-1 receptor agonists could be really transformative for our population of patients. They're super expensive, they're difficult to access, they don't work for everyone, and they have quite a side effect burden in themselves. It's going to be difficult to sell them as a universal intervention for people with severe mental illness. PsyMetRiC might be a really good way of helping us to direct those resources to where we think they're most likely to be needed. So Daniel already mentioned, so I've just been funded on an NIHR Advanced Fellowship to take this work to the next level, essentially. I'm going to show you some of the results actually in a minute. So some of that is about making PsyMetRiC as accurate, equitable and useful as possible. I'm going to show you results for each of those bullet points in a minute. But then there's also a big thing, I'm really interested in making sure that the tool has impact when we implement it. There's no point implementing a risk tool that has no impact on anything, doesn't lead to any changes. What's the point? So some of that is about thinking about how we define higher risk, where we set that risk threshold. So engaging with stakeholders to decide that, thinking about how we communicate risk scores. Clinicians generally have a poor understanding of risk, and if clinicians have a poor understanding of risk, how can they have those sensitive conversations with patients in a way that motivates them to change and doesn't lead to distress? And then thinking about what treatments should we be offering our patients, and then we'll implement it and look at the impact on clinical and patient outcomes. So moving from PsyMetRiC to, well, at the minute we're calling it PsyMetRiC 2 because I'm not the most creative person in the world. So if anyone's got a better name, I'll be delighted to hear it. So in hindsight, maybe metabolic syndrome wasn't the best outcome. So it's not really a sort of disease in itself, it's a risk factor. It's a strong risk factor, and some might call it a predeterminant of later worse cardiovascular or clinically significant cardiovascular outcomes. But the other problem is that clinicians never diagnose it. Clinicians don't generally understand what it is, and patients definitely don't understand what it is. So how can we have these sensitive conversations with patients to help them try and change their behavior to prevent an outcome when they don't know what that outcome is? So we're moving away from metabolic syndrome to more meaningful outcomes. So outcomes that are meaningful and useful for patients, things like, am I going to put on weight in the next year? To outcomes that are meaningful for clinicians. So is this individual going to develop type 2 diabetes in the next 20 years? It's a work in progress. We have an online app that you can use. It's not for clinical use at the moment. We're hoping that will change in the next 6 months. But if you want to have a play around with it, we're on PsyMetRiC.app. So moving to PsyMetRiC 2, we've got a lot of data available. We've got primary care data from 2 sources. So CPRD and Q Research together comprise around 60 or 70 million health records in the UK. We've also got secondary care data, so mental health early intervention service data from 3 regions, so South London, Cambridgeshire and Birmingham. The characteristics of primary versus secondary care data mean that it's better to predict the shorter term outcomes using secondary care data and better to predict the longer term outcomes using primary care data. I won't go into specifics, but happy to talk to anyone who's interested. So the first step was thinking about the predictors that go into PsyMetRiC. The principle of simplicity remains, and I think is really important, but there are some things that we thought might be improved. So step 1 was thinking about the predictors that are already in the risk tool. Can we make those predictors better? So because of sample size limitations, we were a bit limited with, for example, how we coded ethnicity. So previously we only had 3 categories, so massive oversimplification. So we've managed to increase that. So now we include more categories of ethnicity. Previously, we had a binary distinction between more or less metabolically active for antipsychotics. Again, massive oversimplification. So instead, now we're using 5 classes of antipsychotics based on their receptor function, which is a more principled approach. We've also added in a few new predictors. So we've added in glycated hemoglobin. It's routinely collected in clinical services and is relevant for predicting diabetes, for example, in the future. We've added blood pressure. It's a cardiometabolic prediction model. It's good to have something cardio in there. Antidepressant prescription we've included, not necessarily because we're interested in antidepressants themselves, although some of them do have metabolic consequences. More, we're interested in why those antidepressants might be being prescribed. So depressive symptoms might increase cardiometabolic morbidity risk. Then family history of cardiometabolic disorders, which is actually recorded quite well in primary care. So I can show you some results. So we've got results. We've finished our analysis in CPRD. We're just working on Q Research now. So this is for the existing model predicting metabolic syndrome. So you see there's results where for the existing model, so just externally validating in CPRD, the existing model. Then step 1, increasing the granularity of ethnicity and antipsychotic predictors. And then step 2, adding new predictors. So you can see that, well, it was an awful lot of work for a very, very, very minor improvement. But still, I think the point remains, I think that it was a principled approach to predictor selection and one that we're still happy with, even though the improvements in accuracy aren't huge. Saying that though, I mean, this is an external validation in CPRD. We're not far off the accuracy of Q-risk in the whole population at this point. So I'm going to show you some work that we're still working on really, so these are really early results, but I wanted to show them to you because I really like them. So we're now developing a model to predict type 2 diabetes up to 20 years later in about 15,000 first episode psychosis cases in CPRD, so primary care data. We're using a different approach, so flexible parametric methods for our modeling, and I'll come back to why we're doing that in a minute. So we're predicting diabetes up to 20 years later from the same set of PsyMetRiC predictors. So the idea being you fill in your predictor information once on the app screen, and then it gives you all of your risks for the 3 different outcomes on your results screen. The results look good, at least the internal validation. The results look really good. And let's see what happens when we validate in Q Research. So one of the reasons to move to flexible parametric models is because they're really good for visualization. So imagine this individual, 20-year-old South Asian male, BMI is on the upper end of normal, but he's got normal blood pressure, relatively normal HDL and triglycerides, HbA1c maybe a bit on the upper end of normal, and his father has type 2 diabetes. Using PsyMetRiC, we see that his 10-year risk is 12%, but his 20-year risk is close to 40%. So you can see how risk changes over time really well with these sorts of models. And in terms of a visualization tool and a tool for clinicians to show patients, I think this a method like this could be really valuable. The next thing that's good about these sorts of models is, hold on. Oh, it's not. For some reason, it's not showing, but what was on my slide that seems to have disappeared are confidence intervals. So we can see with the flexible parametric models, we can start to capture the variability in the risk estimates. So that is really important. I'll come back to it again in a minute, but going back to what we do with Q-risk. So Q-risk, we have a binary, very specific threshold, 10%. You have to get to 10% if you want an intervention. Really, that individual's risk could be anywhere, probably between about 8 and 13, 14%, something like that. So there's a really good chance that actually this individual does need treatment, and that we're not capturing that in how we present that information, both to clinicians and to patients. I'm sorry I can't show you that on the graph. The next thing is motivating change. So this is what we're dreaming up at the moment. So imagine an app screen that looks a bit like this. So there's a box for the individual where you fill in your individual's information. There's another box for a similar individual for comparison. And this relates back to how I've seen tools like Q-risk used. They're misused all the time. So what I have seen with my own eyes is GPs filling in a risk score for a patient, then pressing back and saying, well, if we stop you, if you stop smoking, this is what your risk would be. That is assuming causality, which we cannot do with prediction models. However, there is a philosophical point, which I won't go into more about. If we know this is the individual's risk and we want to help them to achieve a behavior change, does it really matter if people are misusing those tools? Nevertheless, we want to help people to use these tools properly. And another way that we can appropriately consider a comparison is by thinking of a similar individual to you, but whose potentially modifiable exposures might be slightly different. That is an appropriate way to think about these things. So imagine another box to the right where we only allow someone to enter the perhaps more targetable risk factors. So things like BMI and smoking. So we can't change age, we can't change sex, we can't change ethnic background, and we can't, but we can change we can work on BMI and we can work on smoking. Then we can plot what the difference in risk might be. So let's just say for one individual, similar individual, but whose BMI is 23.5 instead of 24.5. And because their BMI is lower, maybe their HDL and triglycerides are slightly better as well. And maybe their HbA1c is slightly lower as well. This is what their risk might look like. So this leads to a more informed and a more appropriate conversation about risk. So we can't say, what is really important is that this is what your risk would be if you lost a bit of weight. What we can say is that your risk might be somewhere in the middle if you were able to lose a bit of weight. Your risk would be closer to that blue-green line. So now coming back to thresholds and interventions, and I sort of touched on this already. So with the variability in risk, it's really difficult to predict the future, right? So if it were that easy, I wouldn't be here now. I'd be sitting on a beach somewhere because I'll have won the Euro Millions like 20 times in a row. It's really hard to predict the future with certainty. There is always uncertainty in risk estimates, and that is not being captured in the general population-based tools at the moment. And that really has problems when we think about having really binary thresholds for when we offer interventions or not. So another approach might be something like this, where we maybe have gradations of risk. So lower risk, moderate risk, higher risk, and these will be stakeholder-defined thresholds. And then on that, we can plot a whole range of risk where that individual sits and where we're more confident that that individual's risk is. That might lead then to more informed conversations between health professional and patient. I'm really keen that we avoid really set interventions. So for anyone above this risk tool, you should be doing this. Because what is the point in offering or prescribing metformin for patients who are prescribed injectable medications and who refuse all tablets? What is the point offering nutritional advice and support to patients who have no cooking utensils? I've visited patients at home who live in shared accommodation whose shared kitchen only has a microwave. How are we going to, what is the point in just offering nutritional advice with nothing else for those in those cases? What's the point in offering attendance at physical activity groups for patients that can't afford appropriate clothing or footwear? So maybe a better approach, and maybe a different approach, might be an ethnographic approach to contextualize risk scores within the life and the environment of that individual. Taking that number and put it in the context of the individual's life and finding the small things that you can work on to help those individuals improve their physical health. It's going to be a nightmare for guideline writers, but I think that's the approach we need to take. All good so far. So let's just stop there. Let's just implement this thing. Let's see it rolled out. So not quite. I'll introduce the second plot that I want to teach you how to read today, and it's going to be relevant for the next slide. This is called decision curve analysis, and I don't blame you if you've not seen a plot like this before, but I'll teach you how to read it. It plots the clinical usefulness of a prediction model. Along the x-axis is your risk threshold. This is the amount of risk that you might tolerate before an intervention is deemed necessary. So for Q risk, that risk threshold is 10%. Anyone above 10%. We tolerate a risk up to 10%. Anyone above that gets the intervention. That risk threshold might change depending on the intervention that we're considering. So at the one extreme is a risk threshold of 0. That would be a universal intervention. Everyone will have a risk score above 0. We offer the intervention to everyone. All the way through to having a really high risk threshold. These are really risky or really expensive interventions that we really want to restrict to those individuals who are super high risk. Along the y-axis up is the net benefit. The net benefit is the proportion of cases or future outcome cases that you can prevent from developing that outcome at a given risk threshold. So in decision curve analysis, we customarily compare against competing extremes. So that's what the black line and the grey line represent. So the black line is probably easier to understand. That's offering the intervention to no one. So the black line it stays at 0 in terms of net benefit. We're not offering the intervention to anyone. There's no net benefit, but there's also no net harm. If we offer the intervention to everyone, then that's the grey line. That's the grey line. So beyond a point, if we think that the intervention is risky, beyond a point, it's not better to offer the intervention to everyone. So that's where the grey line crosses the 0 on the y-axis, and then it becomes harmful to offer that intervention. What we want to see in a prediction model is for a decision line or clinical usefulness line that is to the right of offering the intervention to everyone and above offering the intervention to no one. It's better to use the risk tool to guide your treatment decisions. This again shows you that this specific decision curve plot shows you actually the changes that we made to PsyMetRiC have just had really, really incremental small improvements on its clinical usefulness, but perhaps more at higher risk thresholds. The reason I wanted to show you that is because of this. So one thing that we're really keen on doing is not propagating existing health inequalities in this population. When we stratify by ethnic background and look at clinical usefulness for people of different backgrounds, we see that there is one group that sticks out in terms of having lower net benefit with PsyMetRiC. You don't even need to, didn't even need to teach you how to read a decision curve plot. There's one line that sticks out like a sore thumb. People of black backgrounds, and this plot caused me a lot of stress when I saw it. And actually, you can see that problem still remains even after we adjusted ethnicity and even after we added new predictors. It didn't change the picture. And actually, at some risk thresholds, the picture has actually got worse. This is potentially a problem, and it needs solving. I'm not going to go through this slide in detail, but just to show you that we really have thought in detail about data-driven ways that we might try to fix this problem. I'm not going to go through it now, but we have thought about an awful lot of things that we might try and do to try and fix that picture. What we do about it is really complicated, but it is so consequential. So there is, you may or may not have heard of the PREVENT equations. These are the cardiovascular prediction models being used in the States now. The sample size was huge, like millions. These are being routinely used in the States. Or I think they're about to be routinely used in the States. That was published in 2023. They made the conscious decision, the authors made the conscious decision to not include ethnicity in the model because they say that ethnicity and race is a social construct and there are better ways at capturing that risk. By taking ethnicity, so that was a principled approach that I think was done was well-intentioned. More recently, JAMA have published, or a article in JAMA has published what the impacts of that are likely to be on who receives treatment in the States, cardiovascular preventative treatment. And no surprises that by making those changes to try and, which were well-intentioned changes, people of ethnic minority backgrounds are far less likely now to receive treatment, preventative treatment for future adverse cardiovascular events. It's had that real unintended consequences, and I think it's a big problem, but it shows how important these decisions are. Now now you'll see two plots. They're both exactly the same. We've done nothing with the data. We've done nothing with the model. All we've done is change how the y-axis looks. So the net benefit versus standardized net benefit. So on the left is the unstandardized net benefit on the y-axis. What that means is that this is the total prevalence within each group of cases that we can prevent at a given risk threshold. On the right, we've standardized. So now for all ethnic groups, it's a total proportion rather than the prevalence. You can see that when we standardize, actually, we don't see that problem anymore. The problem is in the unstandardized graph. What that tells us is the problem is that the prevalence in the data in people of black backgrounds is lower. So compared with other ethnic groups. So therefore, we can't have as much net benefit because there are according to the data, fewer cases to prevent. That disappears when we standardize. It might be that people of black backgrounds are less likely to develop cardiometabolic outcomes. I don't think that is likely. It is also possible, though, that, but that is what the data shows us. So there is a lower prevalence of cardiometabolic outcomes in people of black backgrounds in electronic health record data. It also could be possible that there are some barriers and health inequalities that may disproportionately affect some groups that mean they're less likely to attend a health professional to receive tests. And if you don't receive a test, how can you get diagnosed? So maybe the data is the problem. The prediction models, any data analysis that we do on health records or any other data set really, it's like a mirror of the data that we're doing the analysis on. And that data is a mirror of society. So if society is a problem, if society has a problem, then the data will have a problem, and then the tools that we develop using that data have a problem. A good analogy I really like, it's not my analogy, but a good analogy that I really like is that if you're on your way out to see your friends for dinner or drinks tonight, and you catch a glance of yourself in the mirror on your way out, and you see that you've got a stain on your top, you don't respond to that situation by rubbing the mirror. That doesn't fix the problem. So maybe the way that we address these biases is outside of the data and outside of the model, and it's how they're implemented. That's how we address the problems. The issue is relevant for all of us. So whether we're doing analysis on health record data or just data sets, there's a growing understanding that inequities in data sets are leading to problems with our research and particular problems with any data-driven tools that come from our research. There are a set of guidelines that I really recommend you reading for how we address, or at least show that in our work, and how we might improve data sets in future. And maybe the way to fix this problem is if we can address some of the barriers that exist in society, our data sets will be improved, and then the tools that we develop from our data are likely to be improved too. And with that, I'll finish. So just to say, I've shown you lots of work today, and there are an awful lot of really clever people that have inspired me and helped me with this work. These are just some of them. Thank you very much for listening. I'll take any questions.
Fantastic. Thanks, Ben. That was really super interesting. I'm sure we've got some questions. We have time for some questions. And I know there's a couple online already. Anyone in the room? So we'll start with Andrew.
Of the early deaths of our patients, and I'm trying to engage with GPs, etc., to change the narrative around this. It's not about monitoring the side effects of medicines. It's about recognizing that we've got vulnerable people who need, I guess, in my view, core primary care interventions to reduce their risk. How do you think we can actually kind of use this sort of work to kind of shift that debate to where it should be, rather than kind of the old tropes? And I do think as a profession, we need to take some responsibility for these really detailed monitoring schedules for antipsychotics, which imply that we agree that it's the side effects that are causing this early death, and that's all we're interested in.
No, I completely agree with your point. I think the problems tend to emerge together. People develop psychosis and they have some cardiometabolic changes at baseline. We then treat antipsychotics, the cardiometabolic problems get worse. So it's easy to see why people completely blame the metabolic consequences as being solely related to the antipsychotics. I completely agree with your point. We need to change the narrative. Actually, I think what we found in the modeling is that there are very little differences between which antipsychotic you might be being prescribed at the start and your risk of diabetes. And it's one of the reasons why, when it is with that sort of similar individual box, we're not going to include medication, because we want to move the discussion away from medication and onto other things that we can do to help improve their physical health, regardless of medication. I think it's a really important point.
Rehab psychiatrist, so I'm guessing dealing with people 20 years down the line here. I mean, is there work to expand this from a focus on first episode psychosis to, I guess, the full psychosis spectrum?
Yeah, I completely agree. I think all of what I've shown in terms of like PsyMetRiC being a first episode tool is that really, if we want to get an accurate tool, we need to narrow in our population of interest. So a general population-based tool is aiming to be generalizable for everyone. And what you get from that is a tool that isn't really accurate for anyone. So if we can make tools that are maybe more specific to sort of defined populations, we'll have more accurate tools for those populations. We do have tools for older adults with severe mental illness. So Primrose is one. It's not approved as a device, but it's shown comparative or better accuracy than, say, QRISK in older adults with severe mental illness. But I think broadly there are groups who are at higher cardiometabolic risk. So first episode psychosis is one. There are lots of other groups. Having specific tools for those groups is probably the way forward to make a tool that's more accurate for everyone.
Okay, thanks. Ian?
Thanks very much. Really interesting and valuable work for particularly for young people in prevention. You mentioned at the start the importance of insulin resistance and elevated insulin as a predictor of onset of metabolic syndrome. Obviously, insulin isn't routinely measured in a lot of clinical practice, but are there proxy markers like triglyceride to HDL ratio you could use, for example, to help these calculations to be more predictive?
Yeah, it would be great if fasting insulin or HOMA was measured in everyone routinely. That would be a brilliant change to routine practice, but if it's unlikely to happen in anytime soon, that's specifically why we included HDL and triglycerides in the model. So they are the other two sort of bits of the triad for insulin resistance. So we're not necessarily interested in HDL and triglycerides, but we are interested in how they might be a proxy for insulin resistance at baseline in something that's routinely measured. So triglyceride to HDL ratio is, yeah, it is seen, particularly in kids where we can't strap them up to the hyperglycemic, euglycemic clamp, insulinemic clamp thing, the gold standard measure of insulin sensitivity. So triglycerides and HDL ratio is used in kids in the general population as a proxy for insulin resistance. So we could bring that to routine practice quite easily.
And does that affect the accuracy of the short version of the survey, because that's not included in the short version? So does that mean insulin resistance is less accounted for in the short version than the kind of long version?
Yeah, so I didn't really go over that in detail. So everywhere we've tested, we have essentially found the same thing, that the version with blood test measures is slightly more accurate than the version without. The version without is still accurate, and it's still comparable in accuracy. The confidence intervals tend to overlap, but there is real value in including the biochemical measures where they're available.
Thank you.
Thanks, Ben. So we'll go online in a second, but before we do, can I ask you, presumably you're not just interested in good cardiovascular outcomes for patients, and presumably some of the screening and the subsequent interventions are actually helpful for their mental health outcomes as well. So is that an area that you're measuring or interested in? Or
yeah, we have there's work ongoing to look at actually how well PsyMetRiC scores at baseline might predict later psychiatric outcomes as well, and I think the results are fairly promising with that. I haven't got anything to show today, but yeah, so
just by virtue of giving people a score, that can improve their mental health outcomes.
So I think lots of the physical health interventions that we hope might be offered will improve things other than physical health. So being involved in physical activity groups and in terms of social inclusion and mental well-being, they're super valuable outcomes that will be a side effect, but such an important side effect of PsyMetRiC.
Yeah. So do you want to, Jess, maybe you could read out some online questions?
Yeah, sure. We've got two questions from Charlotte Hanlon online. So the first one is a systems thinking causal loop analysis of the WHO framework on excess mortality in people with SMI indicated that poverty, stigma, and low social support were the key drivers of poor physical health. To achieve impact with PsyMetRiC, will you be considering this?
So I think achieving impact with PsyMetRiC is probably going to be the rest of my career and beyond. I think it's something in general that has been an afterthought with the routinely used tools. We implement them, we don't really look at impact and how they actually change practice. So there's quite good evidence that general population-based tools, they're really good at making clinicians reach for their prescribing pads, but they don't change patient behavior, not much. Achieving impact at both clinician and patient level is super critical to the success of the project in general, and in terms of prevention for cardiovascular outcomes in this group. I think all of the things that were mentioned in the comment are super relevant, and will need to be things that are taken into account in the implementation drive.
And then the second one, Charlotte says, I'm interested in addressing excess mortality in people with SMI in low and middle income countries. How did PsyMetRiC work in India? Was the Indian population rural/low SES or urban/affluent? I'm wondering how the background levels of nutritional status/infectious disease could affect risk prediction.
Yeah, that's an ongoing piece of work, and I don't have results to show today because we're having to make quite a lot of changes to PsyMetRiC to make it relevant and useful for lower resource settings. So we have a piece of work with in collaboration with the University of York and in India, Bangladesh and Pakistan, where we're essentially going to validate the risk tool and essentially probably change it quite a lot to make it relevant for lower resource settings. I think it's a really important piece of work. And I think in general, Western risk prediction tools aren't taken to lower resource settings, but that's where the clinical need is globally. So I think it's going to be a really interesting piece of work, although it will present some challenges, I think.
Okay, fantastic. Any final thoughts, comments, questions? Just one more, Christina, if you're quick.
Thank you. That was a really interesting talk. So you mentioned that clinicians don't always use the PsyMetRiC tool correctly, and you gave the example of them like going back and changing the smoking status. And maybe this is a bit of a naive question, but I just wanted to clarify how you would interpret that result if you saw like a reduced risk after changing the smoking status. For the same individual, like how would you then like interpret that result?
But they're not the same. So that we shouldn't be interpreting that result. The correct interpretation of that result is that's a different individual who probably hasn't smoked for, I don't know, however many years, and is probably from a different background that led them, and a completely different background that led them to not start smoking at that age. So that's the correct interpretation. You can't really equate, you can't really do that.
Thanks. Yeah, that makes so much sense.
Okay, we're out of time, Ben, unfortunately, but thanks again for a fantastic talk and great discussion, and we'll continue it later on this evening as well. Thanks again. Cheers.
Thanks, everyone.